So thank you very much for inviting me, dear faculty, dear ladies and gentlemen, to give my talk from rehabilitation to prehabilitation, what is new for 2022. So prehabilitation, what is new? And there's an umbrella review of systematic reviews that came out on prehabilitation in adult patients just recently. And as you can see here on the slide, this is the evidence map and the grading, and you can see here lilac is protective, and these darker ones are no effect. And as you can see here are the grade of certainty. So this is very low certainty, the red ones, and these other ones are low to moderate grading. And what you can see here is that for orthopedic surgery or for cardiovascular surgery, there is some effect, but the level of certainty that this is really protective is very low. And now we could stop here because the umbrella review says, okay, 55 systematic reviews included, so what else? But I think it's important to have a look on these different evidence-based references. And as the authors already stated, there are major flaws. And the major flaws are reporting on the patients, on the interventions, and the outcomes. And I think this is important if you look on rehabilitation, that we choose it for the right patients. Together with patients, we do the right interventions, and we really measure the right outcomes. So rehabilitation or prehabilitation is a process of risk management, and the key elements here are identifying the risk, assess the risk, treat the risks, and monitor and report the risks. And many things are on identifying the risks. So if you look on elderly patients, and this was just recently published, and what you can see here, 44 studies were included, and the outcome was complications, length of stay, functional decline, and mortality. And as you can see here in older adults, that the geriatric syndromes of frailty or cognitive impairment are much more relevant for the development of postoperative complications than compared to traditionally assessed prognostic factors such as age or such as the ASA status. And this is dependent that the understanding of these geriatric syndromes is often related on increasing frailty that has some comorbidities, that has physiological changes, and these are often disabilities behind that. That means frailty is an inducer of functional decline, of cognitive decline, and on mental decline. And that means all these needs to be assessed and understood to really improve the outcome for elderly patients. So looking on the outcomes on rehabilitation, then you find that frailty and surgical outcomes are very well associated. And what you can see here, that any frailty scoring that's really taken into account gives you a measure of outcomes. And as you can see here, non-frail patients compared to frail patients have a long-term cognitive and functional outcome that is really decreasing. This is also related to postoperative complications and also related to mental disabilities. We also found this situation, for example, in preoperative frailty. We measured preoperative frailty in more than 1,000 patients, and this is what you can see here is the percentage of patients aged above 65 undergoing surgery, and here is high, intermediate, and low surgical risk. And what you can see is 1/3 is not frail, but nearly half of the patients already were frail, and more than 10% pre-frail, and more than 10% were frail. And that means that there's an increasing tendency that patients get pre-frail if they are scheduled for surgery, and that patients already have frailty. And if you look on the complications, you see that the complications go up. And what I think is much more important is that in non-frail patients, they can go home, but the majority of these patients also can go home, but many of them have, for example, 1 out of 15 here in pre-frail patients cannot go home anymore, and 1 out of 5 to 6 cannot go home in frail patients. That means they are very often discharged to care facilities, and that means that these patients might benefit from rehabilitation instead of rehabilitation. Looking on rehabilitation, you can see that patients with pre-frailty and frailty have more complications, not age. It's related to polypharmacy, that's already seen, but it's not, for example, related to organ complications such as cardiac diseases. So this is relevant to know that the usual measures don't work on these patients. In addition, the current guidelines, what do they say? They say we recommend the implementation of functional measures such as level of independence, frailty, and level of anxiety in preoperative evaluation. And I think this is important, in particular in patients who are elderly patients. I think it's very important that we measure independence and frailty before we start with our surgery that's scheduled. We discuss it with our surgeons. And also level of anxiety is relevant because many of the patients are afraid of cognitive and functional decline after surgery, and this need to be addressed. So looking on the rehabilitation, what can we do? We use the frailty phenotype. There are 80 measurements of frailty around, and I think it's not so relevant that we take one. It's important that we take one. It's not so relevant what we take. And we take a very easy one that's from Fritz. And you have 5 criteria. That means weight loss, weakness, exhaustion, reduced activity, and slowness. And you can measure that by different parameters. And importantly, 0 of these criteria means non-frail. 1 to 2 means pre-frail, and 3 and more means frailty. And this is related to these outcomes I've already showed to you. What about the transition of the frailty status? If you look on the frailty status and you look in the participants, and this is the change of the frailty status after 1 year without any intervention, you can see that frailty is progressing very often from non-frail. Many get pre-frail, and also from pre-frailty, many of these patients also get frail and die. And compare the death rate from frailty and pre-frailty, it's 10 times increased with frailty. In addition, patients can improve afterwards. They can get to pre-frailty, or even they can get non-frail. And this is very important, how you intervene and how you give support in these patients and how you can really act. But it's not much known about that. And I think this is a very, very relevant process, in particular for anesthesiologists, because we have a standardized situation of interventions, of surgical trauma, of anesthesiological trauma, and all these gives you the situation that these patients really can improve or can get worse. What are the predictors in frailty transitions in men? As you can see here, for example, predictors are limitations in activities of daily living, low-level albumin, high-level interleukins. That's immunological and nutritional aspects, plus, for example, organ diseases also give you more progression to pre-frailty. But look on the other side. So greater physical strength, being married, having good self-reported health. That means all psychosocial, mental, cognitive, and functional improvements gives you a more a better outcome. And very often these patients can also come back from frailty to pre-frailty again. What are the trajectories after frailty after hospitalization? And what you can see here, that the transition from non-frailty to frailty is much more increased if patients are hospitalized, and patients die more often if they are hospitalized, and also from pre-frail to frail is increased, and also to death is increased. And the other way around is not that much. So people cannot really improve from frailty to non-frailty in many of these settings. But you can decrease also the frailty aspects if you really improve the patient's outcomes with a better standardized care. And I think this is important. This need to be evaluated also for anesthesiologists, and we take responsibility for that. And I think for frailty assessment, we know the risks. We know the risks in these elderly patients. So, for example, peripheral surgery, hip and knee replacements have a higher risk to progress to, if the patients have a higher risk of frailty and a higher rate of death. And this is relevant also for peripheral surgery. And it's not only related to vessel surgery or to any organ surgery in the abdominal or thoracic part. So this is important that we see a lot of these patients progressing. What can we do? We can do a lot. I think the most important thing is that we are involved in the mini geriatric assessment, so we know what our patients have, that they have physical, cognitive, or mental disorders. We know about their components that this is involved, and this has changed in our pre-medication clinic a lot. Since we do that in elderly patients of 70 years and older, we know exactly that these patients have deficits that are not detected by other measures. And I think this is important to find a way for prehabilitation in these patients. This is also seen in the effect of frailty screening initiatives with surgeons. And what you can see here is that the RAI in the most dependent on nursery care patients, as you can see here, the survival is low. But if you have that frailty screening initiative, you see that the survival is much better also in those patients who have a higher nursery care level. And its improvement is greatest among the frail patients from before to after frailty screening implementation. That means there is a rehabilitation potential that's not only solved by rehabilitation. I think this is very, very important to address that. On the prehabilitation, it's also based on shared decision making. So the summary of the surgeons already said what's the big deal about frailty. I think it's important that we have a shared decision making process for surgery and anesthesia. We have a preoperative and interventional management, intraoperative and postoperative management, and this is important to improve outcomes. All these items are important, and it should be based on evidence-based medicine. In addition, patients who are really sick and they have a risk that's too high to perform the surgery, I think these elderly patients have a voice and they require advanced care planning. In addition, all patients with frailty or pre-frailty require advanced care planning because nobody knows what the patient really wants at the end and how the patient wants to survive. I come back to that, what I said in the beginning. It's so important that we consider if a patient is really respecting functional or cognitive decline, or if the patient cannot really cope with that. And I think also with the relatives, it's important that they are prepared. And the majority of frail older individuals would like to discuss end-of-life care and would like to say what they want and don't want. most individuals do not have that opportunity. In Switzerland, for example, everybody has an advanced club playing, not so in my country, but I think it's important that people can say what they want and don't want. And there's a wide range of barriers identified here, and the challenge is to find an effective way to encourage this dialogue and choice within the constraints of the current healthcare systems and the personal circumstances that's really different from country to country and from family to family. What we do now is a frailty assessment in all our patients. This includes physical, cognitive, and psychosocial monitoring as well. We have a shared decision-making progress and a shared decision-making program for our patients, relatives, and the involved disciplines. And we have a prehabilitation program. And the important thing is that we use shared decision because it has a 3-talk model. One is to let's work as a team together. So this is important. Have an option talk discussing the alternatives, providing information, and a decision talk, what matters to the patients. And all these 3 phases are intertwined. That means that this 3-talk model of shared decision making is so relevant in our anesthesia department, and in many of these settings it can be easily trained and used for our anesthesiology decision making together with our patients, the relatives, and the teams we are interfaced. And I think then prehabilitation can begin as a strategy to begin the process before surgery, have a multimodal strategy by nature, and this should include physical exercise training, nutritional care, psychosocial support, and cognitive training. And it should be understood as a key element on the patient's trajectory from surgery indication to long term. But the concept of prehabilitation and the trajectories, this is the normal course of an elderly patient. That's the critical zone where the patient gets into after the event, that means the surgery. And this is the course of a frail patient. The patient very often comes never out of that critical zone and worsens. And this is a predictor of death at the end, or a long-term journey of the patient that's really decreasing quality of life. That's why we do that before we evaluate the risk, identify the risk, give the patient a better starting point where the patient can start after rehabilitation. This needs to take at least 3 weeks. And then we hope the patient don't come back to the critical zone and has a better trajectory after surgery. And this involves functional capacity, cognitive and mental capacity, involves muscle and other risks. And also for the geriatric complex patients, I think it's also important that we check for anemia, sarcopenia, anxiety, smoking, comorbidities, and treat them in time to improve the outcome for the patients before we start. We have a better outcome at the end if we check for these modifiable risk factors and can treat them. And rehabilitation programs involve, for example, strategies. Such elements are exercise, for example, endurance training, resistance training, inspiratory muscle training, proprioceptive and balance training, stretching and flexibility. This is all on exercise, and it needs to be evaluated what the patient really requires. Not everything functions, and we should take the most the patient can give out of that, but we should not overdo it and try to bring the patient on the level the patient can achieve, and the patient get worried about his conditions, her conditions. And I think this is so important that we check for that, what the patient really can do, what the patient want to do, and what can be achieved. Also with nutrition, counseling, supplements, and psychosocial, mental stress. for example, anxiety reduction, stress management, but also depression and other things. Risk factor reduction, like cessation of smoking or alcohol consumption or decrease of alcohol consumption. And that can be also, if the patient is not dependent, that can be also an aim, a goal. Other interventions should be general and specific counseling and education. Advanced directives are important. Drug evaluation, transitional care, and post-planning procedures, for example, rehabilitation. That should not stop us from rehabilitation. But I think prehabilitation gives a better starting point, and this gives a better work after surgery was performed. Prehabilitation non-surgical covers functions if there is an improvement of frailty status if it's based on physical, nutritional, cognitive, and combination interventions. This also works with stress, endurance, nutrition, and respiratory therapy. For example, in oncology, gastrointestinal surgery with walking, nutritional support, and respiratory training. 30-day mortality, 3 months mortality was improved. Complications were decreased, and severe complications were decreased. It's small studies, but it's still important to check what works and what does not work, and improve the evidence-based literature by further studies. Respiratory training before major surgery gives you a better outcome, in particular in major abdominal surgery. Also, cognitive prehabilitation on the incidence of postoperative delirium, that's also increasing frailty and also increasing cognitive impairments afterwards, can work if you have a good interventional setting. For example, here, patients above 60 years undergoing major non-cardiac surgery received intervention with electronic tablet-based pre-op cognitive exercise training, targeting memory, speed, attention, flexibility, and problem-solving functions. And the control was daily routine. And you can see here the outcome, the post-operative incidence of delirium. And as you can see here, the primary outcome unadjusted did not show this relevant situation. But if you adjust it, for example, for orthopedic, non-orthopedic, and for example, for baseline frailty associated questions, you have a significant outcome also in that small study. I think this requires further evaluation and further studies, and it's also important for our patients to really give them multimodal interventions. Prehabilitation also works for mental aspects, like seen in psychosocial prehabilitation before cancer surgery is a systematic review. And we see a lot of these things that was evaluated by us with depressive patients. They have prolonged hospital stay, higher rate of delirium, higher levels of pain, lower quality of life, and high rates of infection and mortality. So what do we do with these patients? We have now with the Innovation Ausschuss, we have a German Federal Joint Committee that's usually saying what can be reimbursed and not from the statutory health insurance companies. Together with them, we have a new funding now for rehabilitation, and the big question was pre-frail and frail active surgical patients above 70 years of age. Interventionists, shared decision-making conferences, prehabilitation program for 3 weeks, control is standard of care. The outcome is level of nursing care dependency 12 months after surgery. Our interventions are randomized controlled studies, unblinded, and we have include 1,400 patients, and the follow-up duration is 12 months. Inclusion criteria, as already said, need to be insured by statutory health insurance, frail or pre-frail, expected anesthesia duration above 60 minutes. In addition, exclusion criteria are non-postponable surgery, or if the patient cannot be intervened due to severe cardiac or pulmonary disease, NIHA 4 or GOLD 4. Palliative patients are excluded, and insufficient language skills are also. The project goes started on 2019 and will end 2023. Frailty assessment, shared decision conference, prehabilitation, surgery. And I think this is important that we have here a situation where we have standards of care also applied in perioperative and intraoperative setting. Important is the shared decision progress. As I said already, the patient is in the middle, together with the relative, the GP, psychologists, physiotherapists, nutritionists, and the geriatricians, surgeons, and anesthetists. And they all together make a decision based on that, what the patient wants and what we want to achieve. Rehabilitation program is according to that what's the criteria are involved: unintended weight loss, nutritional counseling, reduction in strength dimension is involved, subjective fatigue, endurance, gait speed, mobility, and reduced activity. The competence in ADL is trained. And there are general factors we assess, and we assess these different factors by different measurements. That's applied in an extended setting if the patient is frail or pre-frail. And then we find out what the patient needs: strength, endurance interventions, balance, mobility interventions. This goes to the shared decision conference. And then the surgeons, the anesthetists, geriatric people, and the physiotherapists and nurses together with the patient and the relatives decide. And then the goals of prehabilitation are set, and the setting of prehabilitation can be outpatient, day clinic, and in-hospital. Specific exercises, for example, are strength training, endurance training, like treadmill, balance training, or prevention programs, mobility training, activity strategies, use of assistive devices, and ADL training. That means procedural training, kitchen shopping, fine motor skills. And plus perioperative and intraoperative measures are important based on evidence-based guidelines like ERAS or others. That, for example, fasting is not 12 or 15 hours, delirium management is involved, neuromonitoring is involved, social binding, nutrition, or immobilization. This is so important that we check for these guidelines to really not worsen the prehabilitation. At the end, I would like to tell you that prehabilitation is a safe procedure, and safety is first. This is reported a longer time ago that encouraged us to really start with the prehabilitation program. So the overall adverse event is really low. Rehabilitation is safe. It requires engagement and organizational skills. And I think anesthetists should take that engagement and these organizational skills to really improve the outcome of the elderly patient. Elderly patients are now 1/3, up to 1/2 of our patients that really have worse outcome if we don't take it serious, if we don't take frailty screenings, if we don't involve the patients and the other disciplines and the relatives, and if we don't perform intervention programs that really gives patients a better outcome because they started on a better point, so they don't have to lose so much if they require surgery and if they require any intervention. So I think it's worth thinking about it. I think it's worth working together as a team to really give that opportunity to the patient and their relatives. And I'm very sure this is the future of anesthesiology. We take that responsibility and take that advantage we have for the patients and with the relatives to really avoid functional decline and cognitive impairment that's so devastating for the patient's end of life. And I hope we will find together as an international society of anesthesiology process is a standard of care in our setting. Thank you very much for this opportunity, and I'm very open for your questions.